In India, pediatric ALF has a native liver survival of 47.7%. The comparative figures in the West are 60%. This is even lower in younger Indian children and in infants. Only 10% of these children undergo liver transplantation, and the mortality rate in pediatric ALF remains close to 50% in India, which is very huge. So I decided to make a video on the diagnosis and management of pediatric acute liver failure, the consensus recommendations given by the Indian Society of Pediatric Gastroenterology, Hepatology and Nutrition, and which has been published in the year 24 itself. But before that, if you are someone who wants to stay updated with the latest, have conceptual clarity, who registers better with illustrations, who wants a succinct summary of most of the topics, and who wants a ready, reliable reckoner, then you must subscribe to this channel, which is a one-stop solution for all your worries and all your queries. Whenever we go through any guidelines, we come across the term level of evidence. What does this mean? It means the type of studies on the basis of which a particular recommendation has been made. Another term is the strength of evidence. Strength of evidence or the strength of recommendation. Whether it is a strong recommendation or is it a weak recommendation. In this video, I have highlighted all the strongly recommended guidelines with a green smiley. Hepatic failure results from rapid and massive hepatocyte necrosis or injury, leaving behind a liver parenchymal mass insufficient to sustain the liver functions. This results in a high rate of mortality. The preceding period for liver failure may last for days or weeks, but once established, the clinical course is unpredictable and often very rapidly progressive. Cerebral edema and systemic inflammation continue to be the major pathophysiological mechanisms driving multi-organ failure in patients with pediatric ALF. So how do you define it? It is defined as per the pediatric ALF study group criteria. Here, the child must not have any known evidence of chronic liver disease, should have biochemical evidence of acute liver injury, that is deranged liver function test, and should have hepatic based coagulopathy, which is defined as an INR more than equal to 1.5 not corrected by vitamin K with clinical hepatic encephalopathy, or INR more than equal to 2 regardless of the presence or absence of clinical encephalopathy. Even though any known evidence of chronic liver disease is an exclusion criteria, as we had seen in the earlier scene, patients with Wilson's disease, autoimmune liver disease, etc., with underlying cirrhosis in the majority are commonly included in the pediatric ALF groups, considering them to be an acute presentation of the underlying chronic liver disease. But there is a need to differentiate between pure ALF and ALF associated with chronic liver disease, since both of them are discrete in the natural course of illness and outcome. To recapitulate, modified hepatic encephalopathy assessment scale has been given for children up to 3 years of age as per the PALFSG criteria. It is one of the most, hepatic encephalopathy is one of the most important prognostic markers. Almost all children have hepatic encephalopathy if they have acute liver failure, but it is difficult to detect early hepatic encephalopathy in younger children. Earlier, hepatic encephalopathy was classified into 4 grades, 1, 2, 3 and 4. Now it has been classified only in 3 grades, that is early, mid and late. The earlier 1 and 2 grades are now classified as early grade. So early hepatic encephalopathy is when the patient has inconsolable cry, sleep reversal and inattention to task, asterixis, unreliable reflexes are normal, or the patient may be hyperreflexic. Neurological signs are unequivocal. Mid-stage, the patient has somnolence, stupor and may be combative. Again, the patient may be hyperreflexic or the signs may be unreliable, and neurological signs are again most likely to be unequivocal. In late stages, the patient is comatose. He arouses with painful stimuli. He may arouse with painful stimuli, the earlier stage 4A, or he may not respond, the earlier stage 4B. Reflexes are absent, and the patient may have decerebrate or decorticate posturing. How should we go about determining the diagnosis then? Etiological evaluation should be undertaken based on the age and geographical location of the patient, and genetic testing using whole exome sequencing should be considered for patients in whom the etiology cannot be determined. This is the flowchart for diagnostic workup as has been given in these guidelines. Here you would see that the investigations are divided into 3 steps, 1, 2 and 3, and the age groups in which the relevant investigations have to be done. Let me magnify the same. These have also been divided into 0 to 90 days, 3 months to 3 years and 3 to 18 years of age, and depending on the age group and the most likely etiology, you can go for the following investigations. About cerebral edema, the guidelines say that clinical assessment is essential but is not always reliable because classical clinical signs appear late in the course of disease, and therefore determination of the optic nerve sheath diameter is useful for the diagnosis of raised ICP and monitoring the course and outcome. This we do with the help of point of care ultrasound. Also, transcranial Doppler can be a useful dynamic non-invasive modality for the same, and reverse jugular venous oxygen saturation near infrared spectroscopy both may be used for assessing cerebral oxygen extraction, which is a marker of cerebral metabolism or cerebral blood flow in patients with pediatric acute liver failure. For managing cerebral edema, hypotonic saline should be used for prevention and treatment of cerebral edema in pediatric ALF. So this is something new which I learned in these guidelines. Hypotonic saline can also be used for prevention of cerebral edema in these patients, and the target serum sodium level should be maintained at 145 to 155 mEq per liter. And mannitol should be used for the treatment of cerebral edema, but care should be taken for patients with renal impairment, that is especially patients with MODS or those with serum osmolality greater than 320 milliosmoles per liter. Again, propofol and dexmedetomidine, there is no consensus for the use of them in sedating intubated patients with ALF, and fentanyl is useful for analgesia in patients with increased intracranial pressure. Thiopentone infusion can be considered in refractory cases, and normocarbia and euthermia should be maintained in patients with pediatric ALF. Euvolemia should be targeted using balanced crystalloids in pediatric ALF patients with careful avoidance of hypo as well as hypervolemia, and advanced hemodynamic monitoring should be done in expert hands to assess fluid responsiveness and tolerance for fluid therapy in patients with PALF. As regards coagulopathy, routine correction of INR is not recommended for low-risk invasive procedures like central venous cannulation. Here I would like that the interventional radiologists make note of this, because even with the help of imagery they refuse to do tough central venous cannulations in patients if the INR is deranged. I would like to stress here, because this is a new learning for me also, that central venous cannulation is to be considered as a low-risk invasive procedure and should be performed even if the INR is deranged, because it is a life-saving thing. Also, hemodialysis, catheter insertion, ascitic tap and pleural tap all are considered to be low-risk invasive procedures. But targeted correction of conventional coagulopathy parameters like INR, platelet count and fibrinogen levels should be done in high-risk invasive procedures, which includes a liver biopsy, whether it is done by percutaneous route or whether it is done by transjugular route. Viscoelastic tests like thromboelastography, whenever available, should be used for assessment and correction of coagulopathy before going for invasive procedures like liver biopsy. What workup should be planned for patients with liver failure then? INR is a sensitive marker and should be done every 8 to 12 hours. See, INR is a ratio of prothrombin time, and prothrombin time is a marker of the extrinsic pathway of coagulation, which includes factor 7 as the main component. Factor 7 has the shortest half-life amongst all the coagulation factors, and therefore we can monitor INR easily every 8 to 12 hours, and the trends in INR can help us prognosticate the patient. Complete blood counts, ammonia and biochemistry should be closely monitored. Target blood sugar should be maintained between 100 to 150 milligrams per deciliter and should be monitored every 8 to 12 hours. Liver biopsy, preferably by the transjugular route, may be considered under expert hands in select cases of acute liver failure when the etiology is unknown, in patients with suspected autoimmune hepatitis, or in patients with systemic diseases, for example, malignancy. As regards infections, blood, urine, tracheal or bronchoalveolar lavage cultures should be performed at presentation depending upon the clinical status, and PCR-based tests may be used if cultures are negative and clinical suspicion is still high. A low threshold should be maintained for initiating prophylactic antimicrobials, which includes both antibiotics as well as antifungals. Again, a new learning for me in patients with pediatric ALF awaiting cultures. Antimicrobials should cover both gram-positive and gram-negative, and not only this, even fungi should also be covered. Modification, that is escalation or de-escalation of antimicrobials, should be performed in hospitalized patients with ALF based on the clinical course, biomarkers, culture and sensitivity, as we routinely do. See, bridging strategies are when a patient develops fulminant or acute liver failure and he requires liver transplantation, but he has to wait in queue due to long waiting list for liver transplantation. Then there are certain therapies which bridge the gap between waiting and liver transplantation. These are referred to as bridging strategies. Most of the time, these are extracorporeal devices, that is, devices which are present outside the body, and that is why they are referred to as extracorporeal liver assist devices or ELADs. These are of three types: biological, hybrid bioartificial devices, and non-biological devices. Biological devices use animal liver. Hybrid bioartificial devices use cultured hepatocytes, which perform both synthetic as well as detoxification functions of liver, and non-biological devices have no synthetic and they have inadequate detoxifying functions of the liver. So, non-cellular or non-biological therapies include continuous renal replacement therapy, therapeutic plasma exchange, and molecular adsorption and recirculating system techniques. And cellular or biological therapies include extracorporeal assist devices and spheroid reservoir bioartificial liver. Therapeutic plasma exchange should be considered as a bridging therapy in patients with ALF fulfilling the listing criteria if transplant options are available. And TPE is basically the removal of 30 to 40 ml per kg of plasma, which is 1 to 1.5 times the plasma volume of a patient, from the patient via a double lumen central venous catheter, exchanging it with isotonic human albumin solution or fresh frozen plasma before blood is returned to the venous circulation. So this is the most closely related bridging therapy to the liver functions of detoxification and synthesis. So it should be performed if the patient is fulfilling the criteria for transplant options but is waiting, and should also be performed if the patient is fulfilling the transplant option but option is not available. I mean, if he is in the way fulfilling the listing criteria but transplant option is not available for him. And therapeutic plasma exchange should be considered especially in patients with ALF due to Wilson's disease, hepatitis A or yellow phosphorus poisoning. Continuous renal replacement therapy should be performed in patients with ALF with persistent acidosis, dyselectrolytemia, fluid overload or persistent hyperammonemia, which is ammonia more than 150 micromole per liter. Molecular adsorption and recirculation system is a device which uses albumin as an adsorbent to remove the potential toxins cleared by the liver, normally cleared by the liver. These include bilirubin, ammonia, free fatty acids and aromatic amino acids. So, infants and children with advanced encephalopathy and multi-organ failure may benefit from advanced or augmented modes of blood detoxification like MARS, and albumin-assisted dialysis may be considered as a bridge to native liver recovery or liver transplantation in patients with ALF with grade 3-4 hepatic encephalopathy. Albumin-assisted dialysis may also be considered for poisoning and toxin-mediated acute liver failure with advanced encephalopathy. There are certain prognostic models in pediatric ALF which can be non-etiology specific models like King's College criteria for non-acetaminophen poisoning, pediatric end-stage liver disease score, model end-stage liver disease score, Children's Hospital of Los Angeles failure score, or they can be etiology specific models like King's College criteria for acetaminophen poisoning, PETS HAV model for hepatitis A, New Wilson's Index and AARC-ACLF score for Wilson's disease, Cauchy's criteria for yellow phosphorus poisoning. So here I have mentioned the King's College criteria, which is used for both acetaminophen induced ALF as well as non-acetaminophen induced ALF. and which can be used for prognosticating the patients despite its low sensitivity. As regards the prognostic scores, the treating doctor must be in contact with a pediatric liver transplantation and should be ready for emergent referral if requirement be. To optimize post-transplantation outcomes, family members should be sensitized and assessed to ensure adequate social and psychosocial support. King's College criteria should be used for listing the patient for transplantation despite it having low sensitivity, and patients not fulfilling the King's College Hospital criteria but INR more than 4 carry a high mortality, and these patients need to be closely monitored at a liver transplant center. While on continuous renal replacement therapy, so these are the recommendations for liver transplantation in patients on extracorporeal life support. So I am not going into the details of these. As regards N-acetylcysteine, it is indicated in preventing hepatotoxicity and reducing mortality in acetaminophen-induced pediatric acute liver failure, and evidence on its role in non-acetaminophen-related acute liver failure is inconclusive. That is, no conclusion can be drawn whether it is good or whether it is bad, but personally, in my personal experience, I have found a very good role of N-acetylcysteine in managing patients with ALF, whether they are of acetaminophen poisoning or not. Specific therapies for various causes of ALF include N-acetylcysteine for acetaminophen poisoning, acyclovir for herpes simplex virus, entecavir and tenofovir diazoproxyl fumarate for more than equal to 2 years, and tenofovir alafenamide for more than equal to 6 years in patients with hepatitis B virus induced ALF, IV ganciclovir followed by valganciclovir for CMV-induced ALF, steroids plus minus immunosuppressors for autoimmune hepatitis, exchange transfusion followed by IVIG for gestational alloimmune liver disease, and chemotherapy, IVIG, corticosteroids, and therapeutic plasma exchange for hemophagocytic lymphohistiocytosis, galactose-free diet for galactosemia, a fructose-free diet for hereditary fructose intolerance, nitisinone plus low tyrosine and phenylalanine diet for tyrosinemia, ammonia scavengers protein-free diet, essential amino acid supplementation for urocycle defect, chelation therapy with D-penicillamine and trientine for Wilson's disease, and enzyme replacement for cholesterol ester storage disorders. In patients with autoimmune hepatitis induced pediatric ALF, patients with coagulopathy and no or early encephalopathy in these patients may be considered for corticosteroid therapy, which is oral prednisolone at a rate of 2 mg per kg per day, maximum 60 milligrams per day, or an equivalent dose of IV methylprednisolone, and the presence of grade 3 or 4 hepatic encephalopathy, or the lack of response within 7 days of institution of steroid therapy implies poor prognosis and necessitates liver transplant in these patients. In patients with hepatitis B induced ALF, the criterion for liver transplantation continue to be the same as the standard indications, and although there are conflicting data, antivirals may be used in children with hepatitis B induced acute liver failure. So summarizing the salient points, genetic testing using whole exome sequencing should be considered for children with pediatric ALF of indeterminate etiology. Clinical assessment is essential but is not always reliable due to the late appearance of the signs. So non-invasive methods like optic nerve sheath diameter assessment, transcranial Doppler, and reverse jugular venous saturation should be used for assessment of raised ICP. Hypotonic saline should be used for prevention also and for treatment of cerebral edema, maintaining a target serum sodium level of between 145 to 155 mEq per liter. Routine correction of INR is not recommended for low-risk invasive procedures, which also include central venous cannulation. Viscoelastic tests should be used for assessment and correction of coagulopathy before invasive procedures if the tests are available. There should be low threshold for initiating prophylactic antimicrobials, which includes both antibiotics as well as antifungals in patients with ALF awaiting cultures. Extracorporeal support systems are available for patients awaiting liver transplantation, and these are referred to as bridging therapies and include therapeutic plasma exchange, continuous renal replacement therapy, and molecular adsorption recirculating system. King's College Hospital criteria should be used for liver transplantation listing in patients with ALF despite its low sensitivity. N-acetylcysteine is indicated in preventing hepatotoxicity and reducing mortality in patients with acetaminophen-induced ALF, and in other etiologies its role is inconclusive but is not negative. Liver transplantation may be considered in patients with hepatitis B-induced ALF for standard indications. In case you like this video, I request you to give it a thumbs up. Write your experience of managing patients with acute liver failure in the comment section below, and please do share the video with those who are willing to learn. Thank you. Thanks a lot.